Hi everyone, this is Neel Raithatha, consultant audiologist and director of WAXscope. Thank you for joining me in my latest video using the WAXscope, and we have a really complex case here. So, of a patient who attended with a collapsed ear canal, and they initially saw a local colleague of mine who really struggled to dilate open the ear and remove this wax, and recommended that this patient come to see myself. And I decided to challenge myself and use the WAXscope for this procedure. Now, it was a very difficult procedure, so I fully understand why my colleague struggled somewhat. And here we've got some matted wax, which is always a bit more tricky to remove because when you've got hairs entangled within the wax, it's very hard to perform microsuction. And I'm using our smaller specular size. So one of the benefits of the WAXscope is that we've got a small specular size which has a 3.5 millimeter diameter, but because there's a slot at the top, and you can see that's where the instrument is entering through the specular, it doesn't obscure the view. So quite often when you're performing microsuction with a microscope or head-worn microscopes and you use a smaller specular, one of the comments I'm reading quite a lot actually, and people commenting, advising me when they come for the training, is that with the smaller size specular, because the instrument would go through the center of the specular normally, it obscures the view. And you can kind of imagine that. So between 11 and say 3 o'clock, you can see there's an opening where this the instrument is positioned. Imagine that rim, that specular going all the way around, and you don't have that opening. And then the instrument would have to go through the internal aperture of the specular, and you can kind of possibly imagine that you're not going to see much other than the instrument. And so that's the advantage of the slot. Initially, when we first developed the WAXscope, I did have a full perimeter specular, which is the normal type. But with the design of the WAXscope, because it's a handheld microscope, if you like, and because it's got a smartphone attached, if you put the instrument to the middle of the specular, so if you didn't have that outer perimeter, it would really, again, like with a microscope and head-worn loupes, it would obscure the view because you're seeing the instrument, but it also blurred the view quite a lot. So after much testing, we went for the slot, and it's definitely the right choice. What do I mean by collapsed ear canal? So the outer third of the ear canal is made up of cartilage, whereas the inner 2/3 of the ear canal is made up of bone. And as we age, the cartilage can weaken, similar to the tip of our nose. So our nose is slightly different. The lower 2/3 of the nose is made up of cartilage, whereas the upper third of the nose is made up of bone. Our ear canal, it's the outer third of made up of cartilage, and the inner 2/3 is made up of bone. But similar to the cartilage at the lower portion of our nose, gravity can take effect over the years. So the cartilage weakens, and gravity can give some elderly patients a droopy nasal tip. And it can work similarly with the ear canal. The canal can collapse. Also, the cartilage of the canal continues to grow, and sometimes, I think it's the back wall of the ear canal near the entrance, it can grow more than the front section of the ear canal. So it loses its center of gravity, if you like, it loses its balance, and so it collapses over. And so with the specular, it is obviously a bit easier. Truth be told, I'm probably a bit more comfortable using the endoscope because I've just developed that technique now to stretch the ear open, even if it's a narrow bendy ear canal. But that's where a lot of specialists would struggle using the endoscope, cases like this. So again, I'm just targeting the back wall of the canal. It's got some skin adhesions here. I'm just rocking it forwards and backwards just to try to loosen it. See, a very hairy ear canal. So we know this patient's of a certain age because, and they're male, because normally you would find this in male patients who are older, because this auricular trichosis, which means excessive hairs in the ear, is quite common in males as we get older. So these hairs, up until a certain age in later life, are somewhat desensitized to testosterone. And of course, men have more testosterone than women. But come a certain age, these hairs then become sensitive to testosterone, and because of the increased testosterone men have, it causes these hairs to become really thick, and they grow. I did a video discussing I had a request actually from an audiologist trying to get some ideas off me about hairy ears, and I explained that I've tried to trim them both manually and electronically, and also we can pluck them, but some of the suggestions were to use blade. Now remember, this ear canal, it's not visible until you put where these hairs are. They're actually internal, and they're not really visible until you put the camera in. And working in a small space like this with a blade would be quite, I wouldn't feel comfortable doing that, or at least training others to do that. And then there was suggestion of waxing, but again, this is inside the ear, so it's been very difficult to wax patients' ears, especially if they're, see, this is when you're sat beside this patient, of course they've got hairs on the outside as well, but these hairs are all internal, so they're not visible until you enter the ear. And this speculum is 3.5 millimeters in diameter, and I'm having to stretch the ear open just to gain access. So in the reality, the canal is almost completely shut, so it'd be very difficult to use waxing or a razor blade, for example, to remove this. But one of the secrets is when you go in with the specular, you rotate it somewhat, so you kind of push the hairs to the side. If you can go a bit deeper with the specular, you can push the hairs at the waist. So the specular enters around 1/3 into the ear canal. That's the maximum depth, because beyond that you've got the bony part of the ear canal. And when you've got the bony part of the ear canal, you don't want to make contact ideally with the specular, because it can be uncomfortable. So these hairs typically are lining the outer third, the cartilaginous portion. Near the entrance, they tend to protrude outwards a bit more, whereas deeper in the ear, they're more flat. But sometimes you get patients who get protruding hairs a bit deeper in the ear. So if you push the speculum a bit deeper in, sometimes you can push them out of the way. Now, I mean, I have used electronic trimmer with some patients, and it kind of works okay, but it doesn't work with all patients, and that's the slight issue. But you can see I've just put the speculum a bit further, and it's just pushed some of the hairs out of the way. And it's when I'm coming away with the specular as I'm removing the wax. So this, you can just see the flesh around 11 o'clock. So this is the cartilage portion. And beyond that, the ear canal is a bit wider. But it's not only the narrowness, it's the bendiness of this patient's ear. So you can see I'm going in with the specular, I'm dilating the ear open, I'm moving the specular to the left, so now I can see the front, so I'm straightening the ear canal as well. And I've just got it in focus. But this patient's ear canal was so bendy that I wasn't able to fully visualize the entire eardrum using the WAXscope. I've got an ENT operating microscope in my clinic, and I've got head-worn microscopes as well. So I examined the ear, both of those. Again, just wasn't able to see the front part of the eardrum at least. The only instrument I was able to visualize the whole eardrum was the endoscope, because the lens is inside the ear, you see. So even in the smallest, narrowest ear we can. So here I'm just really wriggling it, moving it side to side, and because obviously there's not much space, these circular motions are quite small, so I'm doing it a bit faster to try to rock it out, and I've brought it to the entrance almost now. Now I am going to revert to the right, correct, if memory serves me right, to remove this fully from the ear. So you can see we're getting to the entrance. This is where there's more hairs. So it's just trapped here. Because the speculum is no longer in the ear, because obviously the wax has come to that part of the ear, it's collapsed, so the speculum can no longer dilate it. And that's why this wax has got trapped, but there's a little gap at the top. I'm going to go in with the correct. I'm going to gently scoop it out. And there's a bit of wax at the base, so I think I might suction that. Let's have a look. So you're going to lift it up and away and then back out again. So I'm going to enter the ear, really stretch the cartilage portion. And you can see the left-hand side, that's where the cartilage kind of collapsed. You see most of the hammer bone, you can see the posterior inferior part of the eardrum and not the anterior recess, but I looked with the endoscope afterwards and it was completely fine. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.